When it comes to our most intimate health concerns, so many of us grow up without the language, resources, or even the permission to ask questions openly. In many parts of the world, conversations about sexual health and anatomy are considered taboo, especially for women. I often hear from patients who say they never had a pelvic exam, never discussed sexual pain with a doctor, or were taught to think of discomfort during sex as something normal to endure. But the truth, and it's an important one, is that sex should never be painful. Pain during intercourse is always a signal that something isn't quite right, and it deserves thoughtful evaluation and care. Recently, a woman wrote in to share her experience. She had moved to the United States after getting married, and for the first time in her life had a gynecologic exam. In her home country, pelvic exams and pap smears weren't common, and she had never seen a doctor about her sexual or reproductive health. When she and her husband tried to have sex, it was unexpectedly painful, not just once, but every time. She hoped the pain might fade as her body got used to it, but it didn't. Her neighbor was surprised that she had never had a pelvic check up, and she began to wonder if that might be connected to her pain. It's a situation I see more often than people might imagine. And it's such an important reminder that access to sexual health care isn't universal. Even today, millions of women across the world don't receive routine pap smears, pelvic exams, or education on vaginal health. In many cultures, it's considered immodest to discuss these issues, but the silence only deepens the misunderstanding and, unfortunately, the suffering. If you are experiencing pain with sex, you are not alone, and it's not something you need to push through. Pain is never a normal part of intimacy. It's your body's way of saying that something, whether physical, hormonal, or psychological, needs attention. And there are many reasons this can happen. One of the simplest and most common factors has to do with arousal. Women often underestimate how long their bodies take to fully prepare for penetrative sex. Physiologically, arousal isn't just about mental readiness. It's a physical process that can take up to 20 or even 25 minutes. During this time, blood flow increases to the vaginal tissues, the vaginal canal lengthens and widens, and the cervix moves upward to make space for penetration. If you rush this process, penetration can feel sharp, burning, or even stabbing, especially near the entrance or the cervix. Another easily overlooked solution is lubrication. I can't tell you how many people, particularly younger women, assume that using lubricant means something is wrong with them. In reality, even with adequate arousal, natural lubrication varies widely from person to person. It can fluctuate based on hormones, hydration, medications, and even stress. Using a lubricant doesn't mean you're broken or deficient. It simply means you're being kind to your body. Lubricants reduce friction, increase pleasure, and protect delicate tissues from micro tears that can lead to more pain later. But sometimes the issue goes beyond arousal and lubrication. There are physical conditions that can make intercourse painful, and identifying the root cause is essential for proper treatment. One such condition is pelvic floor dysfunction, sometimes called high-tone pelvic floor. The pelvic floor muscles are responsible for supporting the bladder, uterus, and bowel, and they also play a critical role during sex. When these muscles become tense or unable to relax, penetration can feel like trying to push through a wall. It's not on your head. It's a muscular response, one that can be retrained with proper therapy and guidance. Another condition, vaginismus, causes involuntary tightening of the vaginal muscles at the entrance. This can make any attempt at penetration, whether with a finger, tampon, or partner, intensely painful or even impossible. While it often has a psychological component, vaginismus is also a physical response, and the treatment involves gentle, progressive desensitization and pelvic floor therapy, not shame or avoidance. There's also something called vestibulodynia, a term that refers to pain at the vestibule, the small, sensitive area just outside the vaginal opening. This region contains glands and tissue that respond to hormones, especially estrogen and testosterone. When these hormones are out of balance after childbirth, during menopause, or with certain birth control pills, the vestibular tissue can become irritated, leading to burning or stinging sensations right at the entrance. The good news is that once identified, vestibulodynia can often be treated with topical hormone creams or nerve calming medications. In rarer cases, pain can stem from nerve-related causes such as pudendal neuralgia, where the pudendal nerve, which supplies sensation to the genitals, becomes irritated or compressed. This can cause persistent pelvic pain that worsens with sitting or sexual activity. Diagnosis and treatment usually involve specialized nerve evaluations, physical therapy, and sometimes medication to calm nerve sensitivity. Regardless of the cause, The first step is always the same: see a qualified clinician, ideally a gynecologist or urologist who specializes in pelvic pain. A thorough evaluation includes a physical exam, discussion of your symptoms, and sometimes additional testing. It's also important to rule out other potential contributors like infections, hormonal changes, or even emotional factors such as anxiety or past trauma, which can deeply affect sexual comfort. And speaking of anxiety, stress plays a surprisingly large role in sexual pain. Research has shown that when women practice mindfulness meditation for as little as 20 minutes a day, they report not only reduced stress, but also improvements in sexual desire, arousal, and satisfaction. This isn't just about relaxation. Mindfulness helps retrain your body's response to intimacy, reducing the fear and muscle tension that can make sex painful. In one study, women who meditated regularly continued their practice even after the trial ended, simply because their sexual experiences improved so dramatically. This is important because pain and anxiety often create a vicious cycle. The first time sex hurts, you might tell yourself, maybe next time will be better. But if it happens again, your body starts anticipating pain before it even begins. The muscles tense up, arousal drops, and the pain returns, confirming your fear. Over time, this can make intimacy something to dread instead of enjoy. Breaking that cycle takes time, patience, and compassion, both for yourself and from your partner. If you're someone who never had a pelvic exam or who grew up in an environment where sexual health wasn't openly discussed, please know that seeing a doctor about this is not shameful. It's an act of care and empowerment. A pelvic exam is not about judgment. It's a simple medical evaluation to make sure your body is healthy. It can detect conditions like infections, hormonal imbalances, and even early signs of cervical cancer, things that are much easier to treat when caught early. Ultimately, the goal of addressing painful sex isn't just to relieve discomfort. It's to help you reconnect with your body, to feel safe, confident, and free to experience pleasure without fear. Pain is not something to get used to. It's a message from your body asking for attention. And the wonderful thing is, when we listen to those messages, healing is absolutely possible. Let's shift the focus for a moment from pain during sex to another form of discomfort that many men experience but rarely talk about openly: testicular pain. One of the most common concerns I hear, especially from younger men, involves something colloquially known as blue balls. It's a phrase that sounds humorous, even casual, but it often reflects a very real physical sensation, one that can be confusing, uncomfortable, and sometimes even worrying. So let's unpack what's actually happening in the body and why this phenomenon occurs. A young man recently wrote in explaining that he had taken on the No Nut November challenge, a social media trend that encourages men to abstain from ejaculation for a month. He said he had decided to go even longer, waiting to masturbate until he was in a relationship and could have sex the regular way. But as the weeks went by, he started to notice a dull ache in his testicles, especially when he felt aroused. It wasn't sharp or severe, but it lingered, distracting him throughout the day. Naturally, he wondered whether his balls were too full, a phrase many men use half-jokingly, but that touches on a genuine physiological process. What's happening here is something called epididymal hypertension, which is the medical term for blue balls. When a man becomes sexually aroused, blood flow increases significantly to the genitals, the penis, testicles, and surrounding tissues. This increased blood flow creates pressure and engorgement, preparing the body for ejaculation. Normally, when ejaculation occurs, the blood flow recedes, the pressure resolves, and the discomfort dissipates. But if a man becomes aroused and doesn't reach orgasm, the blood can remain pooled in the area for some time, creating that familiar feeling of heaviness or atching in the testicles. It's worth noting that while this sensation can be uncomfortable, it's not dangerous. It doesn't damage the testicles, and it doesn't require urgent medical treatment. However, the pain can be strong enough to cause concern. In fact, there have been documented cases of men going to the emergency room with what felt like severe testicular pain, only to discover that the cause was benign, simply prolonged arousal without release. The relief, both physical and emotional, often came as soon as the pressure was released through ejaculation or as the arousal naturally faded. That said, there's another layer to this story that deserves attention, something that's not as well known but far more significant when it comes to chronic or recurring testicular discomfort. Some men who regularly practice semen retention or who actively avoid ejaculation for long periods may inadvertently develop pelvic floor dysfunction. The pelvic floor muscles, as we discussed earlier in women, play a vital role in sexual function for men as well. These muscles contract rhythmically during orgasm and ejaculation. When a man constantly suppresses this natural reflex, perhaps by clenching the pelvic muscles to prevent release, over time, the muscles can become tense and unyielding. I often describe this to patients using a simple analogy. Imagine your bicep muscle halfway through a curl. Now imagine holding it there, flexed and tight all day, every day. Eventually, your arm would start to ache. You might develop pain, not just in your bicep, but in your shoulder, elbow, even your wrist. That's essentially what happens when the pelvic floor muscles are held in a chronic state of contraction. The body loses its natural rhythm of tension and relaxation, leading to symptoms like aching in the testicles, pain during ejaculation, erectile discomfort, or even urinary issues such as urgency or constipation. The good news is that pelvic floor dysfunction is treatable. Once identified, men can learn how to relax and retrain those muscles through pelvic floor physical therapy, guided breathing exercises, and posture correction. In fact, many urologists now work closely with pelvic floor therapists because we understand how deeply interconnected these systems are. For men who experience recurrent testicular or pelvic pain, a structured therapy program that includes stretches, relaxation techniques, and sometimes biofeedback can make a tremendous difference. Of course, not every case of testicular pain can be chalked up to blue balls or muscle tension. There are other, more serious causes that must be ruled out, and this is where medical evaluation is critical. Conditions like epididymitis, inflammation of the epididymis, or orchitis, a testicular infection, varicocele, enlarged veins within the scrotum, or even a testicular torsion where the spermatic cord twists and cuts off blood flow. A true emergency can all cause pain in the testicles. These conditions typically produce other symptoms as well, such as swelling, redness, fever, or severe acute pain. If you ever experience sudden or intense testicular pain that doesn't improve within an hour, it's essential to seek medical care right away. But if the pain is mild, dull, and seems linked to arousal or abstinence, it's reasonable to start by simply allowing yourself to ejaculate and see whether that resolves the discomfort. If the H persists or recurs frequently, that's your cue to make an appointment with a urologist for a proper examination. It's also important to talk about the psychological side of semen retention and abstinence. Online, there's a growing movement of men who believe avoiding ejaculation will dramatically improve their energy, focus, or testosterone levels. While the intentions may be positive, rooted in self-discipline or personal growth, the science doesn't fully support these claims. Research shows that brief periods of abstinence can slightly raise testosterone levels, but these changes are temporary and minor. In contrast, chronic suppression of natural sexual function can create stress, muscle tension, and frustration, all of which can have the opposite effect, lowering libido and mood over time. From a medical perspective, sexual release, whether through partnered sex or masturbation, is a healthy, normal part of human physiology. It helps regulate hormones, relieve tension, and maintain prostate and pelvic health. There's nothing inherently harmful about abstaining for a while, but long-term avoidance without understanding the body's needs can lead to unnecessary discomfort. For men dealing with lingering testicular pain, I always encourage a holistic approach, address the physical causes, but also check in with the emotional and mental components. Stress and anxiety amplify pain signals in the body, making sensations feel sharper and more persistent. Regular exercise, mindfulness practices, and open conversations about sexual health can all help reduce that tension. Remember, sexual health isn't just about performance, it's about balance, connection, and comfort within your own body. If you've been worried that your testicles might be too full or that pain means something's seriously wrong, take a deep breath. Most of the time, this is a benign and temporary condition. But if your pain doesn't go away, or if it's accompanied by other symptoms like swelling, fever, or persistent discomfort, don't try to tough it out, see a urologist. Getting checked is never embarrassing. It's a smart, responsible choice that can save you unnecessary worry. In the end, the lesson is the same one I share with all my patients. Listen to your body. It communicates constantly, sometimes in whispers, sometimes in discomfort, but always with purpose. Pain, even mild pain, is never something to ignore or dismiss as weakness. It's information, and understanding that information with the help of a trusted medical professional is the key to staying healthy, confident, and fully present in your sexual well-being. As we move from the topics of sexual pain and testicular discomfort into the realm of hormones, it's important to remember that sexual health is never isolated to one organ, one system, or even one gender. The body is a beautifully interconnected network, and few things illustrate that better than the relationship between testosterone, prostate health, and aging. A 69-year-old gentleman recently wrote in sharing that his PSA, or prostate-specific antigen level, had risen from 1.2 to 3.2 within a few months. His urologist had been monitoring his testosterone replacement therapy, which consisted of injectable testosterone cypionate every 10 days, and paused the treatment out of caution. He wanted to know whether the testosterone might have caused the PSA rise and whether it was safe to continue the therapy. It's a thoughtful, important question, one I receive often from men who are balancing the real benefits of hormone therapy with understandable fears about prostate cancer. To understand this fully, we need to step back and look at what testosterone replacement therapy, TRT, is meant to do. Testosterone is a hormone produced primarily in the testicles, and it plays a key role in energy, muscle mass, mood, libido, and erectile function. Levels naturally decline with age, typically by about 1% per year after the age of 30. For some men, that gradual decline goes unnoticed. For others, it can lead to symptoms that truly affect quality of life: fatigue, low motivation, reduced sex drive, loss of muscle tone, increased fat around the midsection, and even depression. When these symptoms are accompanied by confirmed low testosterone levels on blood work, TRT can be life-changing. Many men report that within weeks of treatment, their energy returns, their mood stabilizes, and their sense of well-being improves. It's not vanity medicine. It's about restoring the body to a healthy hormonal balance. However, testosterone's connection to the prostate has been a subject of debate for decades. Historically, doctors believed that testosterone might fuel prostate cancer. This idea came from early prostate cancer treatments in which men were chemically or surgically castrated to halt tumor growth. Since the cancer seemed to shrink when testosterone was removed, the natural assumption was that testosterone must be dangerous for the prostate. For years, this belief guided medical practice. Many physicians hesitated to prescribe testosterone, even for men who clearly needed it. But modern research has reshaped our understanding in profound ways. We now know that testosterone itself doesn't cause prostate cancer. Multiple large-scale studies, including a major randomized controlled trial known as the TR-Varus study, have compared men on testosterone therapy with those who were not treated. The results have consistently shown no significant difference in the rates of developing prostate cancer between the two groups. In fact, some evidence suggests that men with chronically low testosterone may actually have a higher risk of developing aggressive prostate cancers, possibly because hormonal imbalance affects cell growth regulation in the prostate. So, if testosterone isn't the villain, what's happening when we see a rise in PSA during treatment? The answer lies in the way the prostate responds to hormonal changes. Testosterone naturally converts to dihydrotestosterone DHT, a more potent form of the hormone that influences prostate tissue. When a man who has very low testosterone levels begins TRT, his prostate receptors, which have been hungry for hormone stimulation, suddenly become active again. This can lead to a modest, temporary rise in PSA. It doesn't mean cancer is developing. It often reflects a return to normal hormonal function. Once those receptors are saturated, meaning they've received all the testosterone they can use, the effect stabilizes. That said, a rising PSA always deserves evaluation, because while testosterone doesn't cause cancer, if a man already has undiagnosed prostate cancer, the hormone can accelerate its growth. That's why responsible prescribing of TRT includes regular monitoring baseline PSA and prostate exam before starting therapy, followed by periodic rechecks. In this patient's case, his urologist's decision to pause testosterone was medically sound, not because the therapy was unsafe, but because it's prudent to rule out prostate disease before resuming treatment. If further testing, such as repeat PSA, prostate MRI, or biopsy, shows no signs of malignancy, it's entirely reasonable to restart TRT under careful supervision. The key is collaboration, that open communication between patient and physician, consistent monitoring, and understanding both the benefits and the potential risks. Testosterone therapy, when appropriately prescribed, has wide-ranging benefits beyond sexual function. Studies show it can improve bone density, insulin sensitivity, mood, and even cognitive function in some men. It can help reduce frailty and increase vitality as men age. However, like any medical treatment, it's not a one-size-fits-all solution. Men with certain conditions, such as untreated sleep apnea, severe heart disease, or active prostate cancer, may need to proceed with extra caution or explore alternative therapies. It's also worth noting that symptoms of low testosterone can overlap with other health issues. Fatigue, for instance, might stem from thyroid problems, depression, or poor sleep. That's why diagnosing low T shouldn't be based on symptoms alone. It requires a comprehensive evaluation, including morning testosterone levels, sometimes repeated on different days for accuracy. For men navigating this journey, I always emphasize balance. There's no shame in seeking help for low testosterone. It's not a reflection of masculinity or weakness. Hormones affect every system in the body, and treating an imbalance is no different than taking thyroid medication for hypothyroidism or insulin for diabetes. But equally, it's important to approach treatment with realistic expectations and ongoing medical supervision. In recent years, our understanding of male hormones has expanded beyond the black and white thinking of the past. We now know that prostate cancer and testosterone have a far more nuanced relationship than once believed. For men who have been successfully treated for prostate cancer and remain in remission, small, carefully monitored doses of testosterone are sometimes reintroduced safely. The field continues to evolve, but the trend is clear: testosterone therapy, when used appropriately, can be safe, effective, and deeply restorative. So, if you're reading this and wondering whether hormone therapy might be right for you, start by having an honest conversation with your doctor. Bring your questions. Ask about your risks, your options, and the evidence behind each recommendation. A good doctor won't just hand you a prescription. They'll walk you through the reasoning, the monitoring plan, and what success should look like for you. And just as importantly, remember that your overall lifestyle matters just as much as any injection or pill. Regular exercise, balanced nutrition, good sleep, and stress management are all powerful regulators of natural testosterone levels. I often tell my patients, you cannot inject a poor lifestyle. Hormone therapy can be transformative, but it works best when it's built on the foundation of healthy daily habits. In the end, the threads that connect all of these conversations, from painful sex to blue balls to testosterone and prostate health, are simple but profound. Your body deserves attention. Curiosity and compassion, discomfort, pain, or uncertainty around your sexual health are not signs of weakness or shame. They're invitations to learn more about how your body works. Whether you're a woman struggling with painful intimacy, a man confused by pelvic pain, or someone navigating the complexities of hormone therapy, the path forward begins with understanding. Take the time to listen to your body. Ask questions. Seek care from professionals who will listen without judgment. Because the truth is, caring for your sexual health isn't just about improving one part of your life. It's about reclaiming your comfort, confidence, and connection to yourself. You're worth that effort every single time.